So we're very fortunate that we have colleagues from the Center for Medicare and Medicaid Services and no, FDA, sorry, I apologize, FDA, who are going to be speaking to us about approval of devices and coverage decisions. Dr. Hartstein will speak first.
Oh, Michael O'Hara.
Oh, I'm sorry.
That's okay.
I jumped down the agenda. I apologize. Then I was looking one further down. So we're going to hear from the FDA first and then CMS.
Thanks. Good afternoon, everyone. How do I do that? Today, I'm going to try to cover a really brief view of what goes on in the Center for Devices and Radiological Health in dealing with medical devices. So I'm going to talk about I'm going to give you a bit of a summary of CDRH structure. I'm going to talk a little bit about a couple of different well-known components of the Premarket program. I'm going to talk about medical device reporting very briefly, and I'm also going to mention the electronic product radiation control program, and again, a little bit about device recalls. So how does the FDA get involved with advanced technology development? On the CDRH side, we clear or approve new devices for market entry based on safety and effectiveness. And I'll briefly show you those voluminous definitions of safety and effectiveness. I have trouble remembering them myself. This also depends on medical device type and the office division that reviews it. And this is where I want to talk a little bit about CDRH structure with you. The radiological devices are entirely reviewed by the Division of Radiological Health. Surgical devices, surgical oncology devices, they can be reviewed in almost any of the Office of Device Evaluation departments, but the two of the big areas that they're reviewed is the Division of Reproductive, Gastrorenal, and Urological Devices, or the Division of Surgical Devices. The component offices are shown here. The center director is Dr. Jeff Shuren. There's a Center of Communication and Education. There's a compliance center. There's the Office of Device Evaluation, the In Vitro Diagnostics and Radiological Health. That is the office that contains radiological health. Management Operations, Science and Engineering Laboratories is another office. And lastly, Surveillance and Biometrics. These are the people that, for the most part, one of their duties is to run the MAUD database. While all of these offices are involved with medical device evaluation, I'm specifically concerned with the following divisions. Compliance. These are the people that make sure that corporate America is doing what they're supposed to be doing according to FDA regulations and corporate policy. Device evaluation. Device evaluation in CDRH is the 800-pound gorilla. It sees probably, I'll just estimate, 60 to 80% of most of medical devices. And reproductive, the surgical devices, surgical devices and reproductive, gastrorenal, and urologic devices, as I said, those two can see some of the surgical oncology devices. In vitro diagnostics and radiological health, there's a program operations branch, there's chemistry and toxicology, there's immunology and hematology, molecular genetics and pathology, molecular devices, as well as radiologic health. And mammography quality assurance is also part of this program. And surveillance and biometrics, as I said, They're involved with post-market surveillance, the MAUDE database, biostatistics, as well as epidemiology. So I'll start with pre-market. There's a similar approach to surgical devices as the radiation oncology devices in pre-market. And the approach that many people use, or many investigators or companies that want to put a product on the market, they'll call a division management, they'll call a branch management, and they'll start a discussion. If the discussion needs more detail, or the FDA needs more information, which most of the time it does, we go into a pre-submission process. This is a free service that the CDRH asks for a little bit more detail about a medical device, about how the sponsor is going to test it, and what the indication for use of this device would be. So, and it's a way for a sponsor to talk to FDA and get questions answered. The last bullet at the bottom, everybody always has a comment about, but it's not binding on the FDA. And the reason it's not binding on the FDA is because when a device comes into our division, to the Division of Radiological Health, many times the first time we see it, it's not completely thought out. There's data missing, there's concepts missing, or we bring up something that they need to do to get this product on the market. So what we say can change from the initial meeting to a final meeting, but most departments try to stick with their initial discussions. So some of the surgical oncology devices, ablative devices, software algorithms for tumor margins in breast cancer lumpectomy. This is the product, I think it's called Margin Probe. Melanoma diagnosis, a software device, and this is called Melifind. The Division of Reproductive, Gastrorenal, and Urologic Devices. One of the devices that they're currently working on right now are the drug-eluting microspheres for plugging up tumor vasculature. Radiological devices, linear accelerators. All of the linear accelerators, while there's only 2 or 3 that are active, there's a number of linear accelerator 510Ks and PMAs that are still on the books. Cobalt-60 teletherapy units. Again, there's a couple of investigative devices that are going back to using cobalt. Proton accelerators, as many people have talked about, there's quite a number of these regulatory documents that we have cleared over the years. And even carbon ions are coming back. And I describe carbon ions as protons on steroids. The treatment planning software, again, regulated by the Division of Radiological Health. Brachytherapy devices, and the Y90 microspheres, the yttrium-90 labeled microspheres from TheraSphere and Sursphere, those are also regulated by the Division of Radiologic Health. So we have to take a bit of a step back. And we have to, I'll just tell you a little bit about device classifications. Class 1 devices are the lowest risk devices. They're subject to general controls. The general controls are registration and listing of the device. Many of these class 1 devices are exempt from pre-market notification. Class 2, by far the biggest class in CDRH. Class 2 are the moderate risk devices subject to general controls and special controls. Many class 2 devices require pre-market notification through the 510K program, and I'll talk more about that. And lastly, class 3, the high-risk devices, they're subject to general controls and pre-market approval, and I'll talk more about that. This is the official definition of safety. I won't read the whole thing, but we're looking for a reasonable assurance that the device is safe based upon valid scientific evidence. And effectiveness just as long. We're looking for reasonable assurance that a device is effective when it can be determined based on valid scientific evidence that in a significant portion of the target population, the use of the device for its intended uses and conditions of use, accompanied by adequate directions for uses and warnings against unsafe use, will provide clinically significant results. And I did promise I wouldn't say that. Pre-market approval. Remember, these are the highest risk devices. It's called the PMA program. Requires scientific, regulatory, and quality systems review of the sponsor's organization or the company that's making the device. Requires a reasonable assurance of safety and effectiveness, well-controlled clinical studies or other objective information is usually part of this review process, and considers the benefits versus the risk, conditions of device use, device safety, and its performance and reliability. Some of the class 3 devices that I picked at random were the ablation devices, the HIFU ablation devices. These are a PMA device. They are reviewed by the Office of Device Evaluation. The radiation oncology devices, the microsphere radionuclide, they're the radioactive particles for liver tumor metastasis. Spheres is a good example of this. This is regulated by the Division of Radiological Health. And 3D mammography is another class 3 device that's reviewed by the Division of Radiological Health. The product code is an internal classification means used by CDRH for device families. What about the 510K program? It's a market clearance application. This is for class 2 devices. It's a demonstration that a new device is similar to a legally marketed predicate device. And the legally marketed predicate device has to have the same indication for use, the same technological characteristics or differences in technological characteristics that do not raise different questions regarding the safety and effectiveness. This is the Me Too category. Basically what this category says is I'm just like company X's device that's already on the market. I have this additional feature. And it's those additional features that the CDRH gets interested in. 3 examples of 510K devices are the low energy direct thermal ablation system, again reviewed by ODE, variant high energy linear accelerators is an example, and proton systems are also examples. Those, as I said, are reviewed by the Division of Radiological Health. And I wanted to mention a couple of things about the linear accelerators and particle therapy. Linear accelerators and proton accelerators have a long history of medical use that predates the medical device regulations of 1976. Linear accelerators and proton accelerators are usually cleared with a general indication for use. And what that means, it means that they can be used for cancer treatment anywhere in the human body. So if a sponsor comes in and calls out a specific application, FDA then gets real interested in what that indication is, what their clinical evidence is. And in some cases, their marketing material gives the sponsor a hard time when we see what they're actually marketing. So the general tool claim that you can use radiation, you can use a linear accelerator, you can use a proton accelerator to give a dose of radiation therapy is how they're cleared. Now I'll switch gears and talk just quickly about the IDE program. It's a regulatory authority and framework for device clinical investigations. There's a number of different types of studies. Sponsor-investigated studies, which are not intended to support a medical application. Feasibility studies, preliminary safety and effectiveness data in a small number of patients, and these can be used to support a marketing application, and a pivotal study, definitive evidence for the safety and effectiveness for a device intended use, and usually has to be statistically justified with the number of patients. The IDE studies can either be significant risk or non-significant risk. Significant risk, potential for serious risk to the health, safety, and welfare of a subject. It can be an implantable device. It's used in supporting or sustaining human life. Substantial importance in diagnosing, curing, mitigating, or treating disease. Non-significant risk, usually no IDE is necessary. Significant risk are studies that end up being reviewed by the FDA directly. Non-significant risk can use the institutional review board. So what are some of the changes, or what is going on with IDE? Well, IDE cannot be disapproved on the basis of FDA's belief that a study design is inadequate to support a future PMA, 510K, or other regulatory submission. Disapproval is only based on subject safety and protection. CDRH Clinical Trials Enterprise goal, which is a new goal within our office, has trying to make the conduct of trials more efficient and timely in a cost-effective manner. We now have a office-level clinical trials director in all of the offices, and there's a mandate to increase the interaction with device sponsors. And this is the same for surgical devices as well as the radiation oncology devices. So medical device reporting. Surgical oncology device reports are reviewed by the Office of Surveillance and Biometrics and discussed with the Office of Device Evaluation. This is a big difference between radiological devices and surgical oncology devices. Radiation oncology devices, all aspects of the medical device are discussed within the radiation health branch. Let me go back on that. So surgical oncology devices, the Office of Surveillance and Biometrics reviews the medical device reports in MAUDE and discusses the issues with the Office of Device Evaluation. For radiological devices like linear accelerators, the Division of Radiological Health reviews the MAUDE reports and discusses it internally. There's no handoff from one office to the next. This is a little table just kind of summarizes the time frames for medical device reporting. And you can see that deaths have to be reported to the FDA and the manufacturer within 10 days. Device serious injuries have to be reported to the manufacturer, and if you don't know the manufacturer, you can report them directly to the FDA within 10 days. And the rest are all listed in the federal notice as well. A very quick difference to tell you about between oncology, radiation oncology devices and surgical oncology devices is EPRC, and that's electronic product radiation control. It mostly pertains to radiation oncology devices. It's to protect the public from hazardous or unnecessary exposure to radiation from electronic products. Applies to manufacturers. And there are performance standards for a number of radiating emitting products. So the EPRC, some of the types of devices that are covered under EPRC are the old style television tubes, which there's probably none of them around anymore, X-ray security screening systems, microwave ovens, laser products, all kinds, from laser pointers to laser light shows, CD players, and medical or metal halide lighting. On the medical side, we're looking at sun lamps, ultrasound therapy devices, even some of the surgical ablation devices, as well as diagnostic and therapeutic X-ray systems. So surgical devices are usually handled as medical device recall. Radiation oncology devices can be handled as a medical device recall or an EPRC recall. The recalling firm, the medical device recalling firm, has a responsibility to promptly notify its customers of the issues and provide instructions to prevent further problems. FDA can determine if the recall is class 1. In a class 1 recall, there's a reasonable probability that the use of or exposure to a violative product will cause serious adverse health consequences or death. Class 2 may cause temporary or medically reversible adverse health events. Class 3, not likely to cause adverse health events. So what are some of the differences between the two? The medical device recall, it's voluntary, but FDA can order a recall on the medical device side. On the EPRC side, it's for radiating products, linear accelerators, proton accelerators, anything that's electronic that emits radiation. And under the EPRC regulations, manufacturers are required to notify FDA and customers and submit a corrective action plan. Are there differences in the way devices are regulated at CDRH? Yes. Some are regulated from cradle to grave by one division, while other groups hand off to other offices within CDRH. The Office of In Vitro Diagnostics and Radiologic Health is a cradle to grave office. Radiologic Health is a part of that, so we regulate all aspects of radiation emitting products. Office of Device Evaluation is responsible for pre-market reviews and hands-off medical device reports to the Office of Surveillance and Biometrics. And medical device manufacturer compliance is handed off to the Office of Compliance. So this table kind of gives you a little bit of an idea of the regulatory process from cradle to grave and who does it. For surgical oncology devices, the pre-market submissions are handled by the Office of Device Evaluation. 510K, PMA, IDE, they're all handled by the ODE. The medical device reviews are handled by OSB and ODE. The MedSun, it's another reporting mechanism, and that's handled by ODE and OSB. The device recalls for surgical oncology devices is the Office of Compliance. And facilities inspections, or the inspectors that inspect the people that manufacture the medical devices, are handled by the FDA district offices. And you can see that for OIR, for the radiation emitting products, just about all of the regulatory review is done within the one division. And we work closely with the district office on recalls. So what I wanted to say in conclusion is that FDA clears 510K devices, approves PMA devices. Before they are marketed, constantly using the CDRH is constantly using new methods to reduce regulatory burden and increase communications. We follow products once they're on the market, work with firms to remove, repair, replace bad devices, and inspect firms' quality systems. I think that's it. Yep. Thank you.